what I would like to do first of all is introduce Caitlin Broderick, who is our first speaker, and she's going to talk about managing side effects of treatments. So a little bit about Caitlin is that she's the nurse practitioner at Sir Charles Gairdner Hospital, and she's been an oncology nurse for over 20 years, working for 10 years of that with thoracic cancer patients. Since 2011, she's been a committee member of the International Thoracic Oncology Nurses Forum, and she's currently the chair of that committee. In 2019, she very well deservedly was awarded the winner of the WA Nursing and Midwifery Excellence in Nursing Award. And she's got a passion for improving patient care and patient outcomes for cancer patients. Caitlin's contributed to a variety of guidelines, policy and publication, as well as presented in a wide range of audiences at local, national and international level. So I'd just like to say thank you to Caitlin. This is a day off, so she's very kindly given up her time this morning. Thank you.
Okay, welcome everyone. It's lovely to see so many faces. We're very lucky in WA to be able to meet face to face, and welcome to anyone online. I did tell to Lisa she could edit as much as that as she liked, but she hasn't done so. Now, I will get started. As I was given this very broad topic in terms of managing side effects of treatment, where do you start? Because there's so many treatments and so many side effects. So this is really a snapshot and an overview. I understand I won't be asking or answering all the issues, but what I hope to give you is an overview and look at some of the resources and team members you may be able to get help with. I won't be able to stay for questions at the end, but if you've got questions, I'm more than happy for you to email me. And the other thing is that I won't be covering everything in every scenario. So this is a snapshot. So let's get started. So managing side effects of treatment. So I'm going to give you an overview of the treatment choices. What are the side effects as opposed to symptoms of treatment? The brief overview of types of treatment, and I might just stand to down here, sorry. Some of the common side effects of treatment and the experience behind managing 3 common side effects that I'm sure some of you will have experienced, and where to from here. So breast cancer is a heterogeneous disease. Metastatic breast cancer, there's no one algorithm, no one treatment that we can say everyone can have this treatment. You're all unique, you've all got your own breast cancer disease, and therefore the treatments for each of you will be different. When you meet with your oncologist, if you have an oncologist, they will look at many, many things before deciding your treatment. They'll be looking at your age, your comorbidities, have you had previous treatment, your hormonal status, your HER2 status, any other treatments and medications you may be on, as well as looking at your own personal goals. Is it your goal to live as long as you can? Or is it a priority for you to have quality of life over that, or a combination of both, which is most common for most people? And sometimes your greatest wish may be just to get symptom control. There are definitions that's slightly different, and sometimes you hear these terms interchangeably. I just want to quickly let you know, symptoms are normally things that you experience, they're subjective, and they can be caused from disease, whereas side effects tend to be caused from medications or an intervention. And adverse events are often things that are unpredicted. You may have them listed, but we don't expect them to happen. So in talking about treatments and side effects, I think it's important to understand, because before you decide on a treatment, you need to be really clear what the side effects are. Otherwise, you're not informed. So you need to include, the discussion needs to include yourself and significant others with your team. The communication needs to be honest and open. I know some of you may be under an oncologist where you find that tricky, but you can always pull in other members of the team to have that discussion with, or talk to your GP about your treatment options. You need to be able to ask questions about the side effects, informed consent. Now, some of you may have treatment in an area where you need to sign a consent form. Others of you might not, but they assume informed consent. And that means that you understand the treatment you're having and the side effects. So if you're not informed, you need to ask more questions. Trials are often given to you as an option. Well, not often. They may be given to you as an option for treatment. And that means it's not experimental trials. I'll briefly touch on this later, just to give you an overview. And you've got a wider team to assist. Now, Cancer Australia have got listed 10 practical issues that inform best practice and 10 things that don't. And their number one thing that informs best practice for breast cancer patients is having a multidisciplinary team. So this involves a wide number of people, but essentially you should be at the center of that discussion. There's a wide number of people you can talk to. That includes nurses, it includes allied health, it may include a surgeon, a radiation oncologist, your GP, community groups. It's a wide variety, and for each of you, the members of that team will differ, but you can draw in each of those at different parts of your treatment. So disease symptoms, these overlap often with side effects, and it's often difficult to differentiate between the two. So some general symptoms you may experience are pain or fatigue or emotional distress. Some specific symptoms related to where your disease may have spread to, such as your bone. If you have bone disease, you may get pain. It may be acute, or it may be a more chronic, dull pain. If you've had a fracture, obviously that's going to be sharp pain. If you have brain disease, you may feel very fatigued. You may have nausea associated with that. You may have headaches or cognitive decline. Liver function, you may have a loss of appetite, feel bloating, nausea. Your lungs, obviously, some patients get lung disease and they'll become short of breath. They may cough up a little bit of blood. There's all sorts of things that can happen depending on where your disease is. And lymph nodes, once again, you can have pain, fatigue, discomfort. Some patients may be asymptomatic, meaning they have no symptoms, but their disease has spread. And that might show up on a scan or in blood tests. I think the important thing to remember is this is why your treatment may be different to someone else's. If you have symptoms that are severe, we sometimes, or are progressing quickly, we may have to treat you differently to someone who has no symptoms. This is just an example. I could have chosen any study, but it just looks, this particular study looked at a placebo drug compared to someone on letrozole. Now, it's not in the metastatic setting, but what I want to draw your attention to, I'm sorry, the slide is in very small print, but basically you can see in that first column and where it says grade 1 to 2 under placebo and grade 1 to 2 under letrozole, you can see the percentage different in side effects with 13.1% arthralgia, so that's joint pain, and that's in the placebo group, and 15.2% in the letrozole group. And fatigue, same thing, very similar results. And in the diarrhea group, there's actually more people suffering from diarrhea in the placebo group, meaning they had no drug versus the letrozole. So this is how it may be the previous drugs the patient has been on that are still causing side effects. It may be other comorbidities, patients going through menopause, so they're still getting arthralgias and things. So all the things you're feeling, you can't associate them all with side effects from treatment. So the treatment options, I'm not going to be able to talk about treatment options as a whole. I'm just going to give you an overview. So trials are one option. Radiation, obviously, we use this in specific targeted areas where you might be experiencing pain or other symptoms. Surgery can be an option for some patients, particularly if you've got lung disease that you might have to have a pleural drain or something put in. Targeted therapy, that there's a whole lot of things that come under targeted therapies. Endocrine therapies are commonly used, chemotherapies, bone treatments such as bisphosphonates, and supportive care. So some patients may choose not to have any treatment and just treat the symptoms that they experience. So overall, the goal when we're managing side effects, if a patient comes in to see me and they're on a treatment, the first thing you want to do is assess the side effect. It seems simple, but sometimes we gloss over some side effects and we don't assess them fully. So you basically need to have a good understanding of the side effect and also check if the patient started any new drugs since the last treatment, because it could be a drug interaction that's causing the side effect. We look at the severity of symptoms. So all symptoms have a scale. One is the minimal or lesser extent of severity. And 4 is like the severity is increased, 3, it goes up. So if it's a mild symptom or side effect, we probably wouldn't do a lot of intervention, just minor interventions. Whereas if it's on the upper end of the severity, we might have to do other things such as stop the drug, reduce the dose. That's the next thing, change of dose or frequency. We often have the option of adding supportive care. So for nausea, diarrhea, those common side effects, we can add in something to help manage the side effects. And you also have the wide variety of team members that you can draw on. There's a lot of allied health, dietitians, etc., that you can get assistance from. And the last option is to actually overview the treatment plan and see if there's any other options for medicines. So just quickly, the phases of a clinical trial, I won't spend long on this, but just to let you know, if you're offered a trial, it's not something to be scared of. You'll be given a lot of information. Phase 1 is a very small trial. It's not looking at drug comparisons. It's just looking at dose toxicities. The second phase is when we do a slightly larger number of patients in these trials, and we're actually looking at the effectiveness of the drug in that tumor group. And the phase that's most commonly used in tertiary sites is a phase 3 study, and it looks at standard of care, so what the normal patient with this disease type would get, plus the standard of care, plus a drug. An example of this is a phase 3 study looking at ribociclib plus endocrine therapy in breast cancer. Now, this is a phase 3 study because they looked at ribociclib and letrozole versus letrozole, which is the standard of care. Yeah, makes sense? If you're given a trial to take part in, you'll be closely monitored, you'll sign a consent form, and you can withdraw at any time. But just that's the overview. So chemotherapy is often used, you can be used in a single agent. The word chemotherapy is cytotoxic, and it's cytotoxic whether you have it in your veins or orally. It still causes cell death. You can have it in combination. We sometimes use this if your disease is progressing very rapidly or it's causing symptoms. You can have intravenous chemotherapy or oral, as I mentioned. And we're now looking at chemotherapies in combination with immunotherapies, which is really exciting. Side effects of treatment. The chemotherapy, each of you, if you're on chemotherapy or any treatment, should have a written information sheet about that treatment. If you don't, you need to ask for it. And on that list of information, it should have all the side effects. This is just an overview of common side effects, but each of you, if you have different types of chemotherapy, would have a different list of side effects. I guess I want to highlight that the bone marrow suppression is a red flag because this can be life-threatening if you have a low white cell count and you need to get ill and pick up an infection. So if you do this, you must have some sort of alert card that you can take to your nearest accident emergency department and let them know you're on chemotherapy, because it changes the course of your treatment and the time in which you get treated. So if you're on chemotherapy, you must have guidelines as to how to act if you get a temperature. Things like GI changes, so gastrointestinal changes, patients get frequently, and this is where we normally give additive treatments. So anti-nausea, anti-diarrheals, etc. The one thing I will say to you is that it can be very scary if you get a side effect such as nausea and we give you a script. So there's very common side effect medications for nausea such as Pramin, metoclopramide, you may have heard of, the same drug. They have a trade name and a drug name that we will use, generic. And then there's things like ondansetron, which can cause constipation. So some of the treatments we give you for side effects cause side effects. And then the other thing to remember is that sometimes we give you drugs, for example, olanzapine. Some of you may be on olanzapine, and it's actually an antipsychotic drug. And if you take that home and your oncologist or your nurse practitioner hasn't explained to you what that drug is, it can be very scary when you pull out the information leaflet and say it's an antipsychotic drug, and it's actually given to you for anti-nausea. So just be aware that sometimes treatment medications will be prescribed for you. That's not the actual indication of the drug, but we're using it to manage your side effects. Some patients get muscle aches, skin changes, headaches, fatigue, and neuropathy. And I will be talking a little bit about fatigue and peripheral neuropathy. There's many targeted agents. I guess I'm not going to go into this because that's for a different talk, But just targeted agents normally say that they work in a specific area of the cell cycle, or for something like Herceptin, slow down, Herceptin, or some of like hormonal positive cancers, they have like a receptor and the treatment blocks it. Yeah, like an antenna, and you block it. So that's probably all I'll cover in that slide. Side effects, once again, all different depending what treatment you're on. Common side effects. So headaches are common. Some liver blood tests might alter. You might not know that they've altered, but when you come in for your treatment cycle, the oncologist or myself might say, we've got to drop the dose, or we've got to skip a cycle or something like that because the liver function is off. Sometimes you might be referred to different team members. So if you have cardiac toxicities, you might be actually referred to a cardiologist, or if you have lung disease like interstitial lung disease, you may be referred to a respiratory physician. So we draw in different members of the team as and when we need them. Endocrine therapy, tamoxifen, this is generally used in premenopausal women, and aromatase inhibitors are used in postmenopausal. Side effects of treatment for endocrine therapy. There are many side effects, once again, different from tamoxifen to aromatase inhibitors, but very frequently women experience menopausal symptoms. Now, unfortunately, this time you have with your treating team when you go in for a clinic is often limited, and they'll focus on the things that perhaps are important to them and not to you. So you may have problems with sexual problems, with vaginal dryness or anything like this, and feel uncomfortable raising it unless the oncologist or the doctor or the nurse raises it with you. And I think it's really important to know that there are strategies and there are options for you. There are vaginal moisturizers, vaginal lubricants that can be used, and you need to talk to your GP or your oncologist about options if this is a problem for you. There was a recent survey done nationally with breast cancer patients, and what they found was only a third of patients were actually asked about these issues. And 70% of women were experiencing these issues. And so that's pretty poor on our behalf. And so what I'd say to you is, don't wait for us to ask you. That's a gap we don't cover, but feel entitled to ask the question if you are experiencing these symptoms. Fatigue is common, nausea, joint muscle aches, weaker bones, depending what treatment you're on. Some of the activity of the bones is different. If you're on tamoxifen, it can strengthen the bones, but the aromatase inhibitors are different like that. They can cause impotence with men with breast cancer. Some patients may experience increased cholesterol, and with tamoxifen, there can be a minimal group of people that experience blood clots. So I'm getting on to the more specifics of hot flushes. I've just chosen a couple of side effects and things that I felt were common. I spoke to Lisa and we felt we could have a half day on each side effect. So this is a quick overview. But lifestyle is probably the simplest factor you can do to reduce hot flushes, or at least have a go at reducing hot flushes. So that's reducing alcohol and caffeine, weight loss if you're obese or overweight, and make sure you're well hydrated. Sounds simple, probably not so simple to do. Mind-body activities and cognitive behavioral therapy. Now, not anyone can provide cognitive behavioral therapy, but it's about, there's lots of different strategies that covers, but sometimes it's about reshaping the way you think. So if you're in a negative thought cycle where you have negative thoughts and that reinforces negative behaviors, a cognitive behavioral therapy, for example, may look at reframing the way you're thinking. So that's one example of cognitive behavioral therapy, and it may have an impact. When I looked at the evidence behind what works, that's the only treatments we can recommend. So you might come to your doctor and say, I take vitamin E, and if it works and you've spoken to your oncologist about it, they know what you're on, go for it. But I can't recommend it because there's no evidence behind it. Does that make sense? So don't be disheartened if your oncologist tells you we don't recommend it, I don't think you should take it. You need to understand, unless something has shown to be effective, we're definitely not going to recommend it. But you should always let your team know because it may cause side effects. So there's no evidence behind acupuncture, yoga or exercise in reducing hot flushes themselves. Acupuncture is a really hard thing to do in a randomized controlled study, but they have tried. They did this study to look at 300 or so women having acupuncture, and they used sham acupuncture. So they didn't actually break the needles, the skin, and they looked at hot flushes and the severity of them. And what they found was both groups had a reduction in hot flushes. So there's no benefit to the acupuncture group over the sham group, but they both had a reduction. Don't know what that means. Antidepressants. So venlafaxine is a common antidepressant, and this is an example of a treatment, like the drug is used for antidepression, but the side effect is it may reduce your hot flushes. So 60% of women who are on venlafaxine had a reduction in hot flushes, but additionally it improved their mood and quality of life. Gabapentin, pregabalin, sometimes used, not as much evidence, but it can help, particularly if you have night sweats, because it's taken at night and it also can help you sleep. So that's, I guess, the side effect of the medication can actually work in your benefit. Clonidine is also another drug sometimes used, and vitamin E and black cohosh I hear regularly from patients that they're taking, but there's no evidence to support it. Black cohosh I just thought I'd cover because a lot of patients seem to be interested in it. It's a plant. It's claimed to reduce menopause symptoms. There's a systematic review of this drug, and it is a drug used to treat it, and it basically showed no association between this and the vasomotor symptoms. In fact, it caused upset, gastrointestinal upset, and can cause liver toxicity. So definitely, before you take it, if you're keen, definitely talk to your oncologist and look at the evidence. Fatigue is another big issue, both as a symptom and as a side effect. This is one of those things that overlaps. It's a very distressing symptom, can affect quality of life, and it's not proportional to the activity you're doing. So it's not something that you get more tired because you've had a really strenuous day. You're just generally fatigued. The rest doesn't really compensate for your fatigue. It's ubiquitous with cancer, metastatic breast cancer, and treatments. And it can profoundly affect quality of life, and it can affect every part of your life, the economic, your ability to go to work, all sorts of things, your relationships with people. It's underreported and undertreated. So fatigue, there can be multidimensional factors that cause fatigue. So we need to assess all of these areas. So pain can cause fatigue. The treatments we give you for pain can cause fatigue. There can be emotional distress that causes fatigue, sleep problems, lack of physical activity, a whole host of things can cause fatigue. So, if you've got fatigue, we need to look at all these things. What can be done? This is evidence-based, what can be done. You might have other strategies that aren't listed, but we definitely need to assess for all the possibilities. We look at psychosocial strategies. This is an example of where cognitive behavioral therapy can reframe your thinking. We might not be able to do much for the fatigue itself, but it's the way you think about the fatigue and how you're going to manage it. The physical exercise, they did studies where patients did about 150 minutes of exercise. It doesn't have to be overly strenuous. Walking, you don't have to do 150 minutes, but that's what was done, and some resistance training twice a week, and that's shown to reduce fatigue. So any amount of gentle exercise can help. Energy conservation, so this might be as simple as planning your day, setting goals for yourself. Some patients use a bathrobe instead of drying themselves with a towel because they conserve energy that way. There's a whole host of things, frames for walking, commodes, so they don't need to get up and walk so far to the toilet. Yoga is an option, distraction. You can use music, play games. This can be a management tool for fatigue, and sleep hygiene. There's limited evidence for pharmacological support in this area. Pain is another one. There's hard to assess pain. There's a whole host of reasons for pain, and we can use a scale. This is an example of a pain scale. The faces say it all, and the colors. So we use a scale sometimes of 0 to 10, 0 being no pain, 10 being the worst. Where do you pitch it? And we can, the treatment and the side effects depend on how bad this pain is and where the pain we feel is coming from. So sometimes anti-cancer therapy, such as chemotherapy, may be the best attack to manage pain. Sometimes there's a pharmacological pyramid. So we start with simple analgesia like Panadol, anti-inflammatory drugs, sometimes steroids, and then we step up to weak opioids. And then the top of the pyramid is stronger opioids. We can use fast acting ones that work really quickly, or we can use really slow acting ones that last you a day, and they can be up titrated. We can swap opioids. There's a whole host of things. You can take them orally. They can come as a patch under your tongue, all sorts of things, depending what we need. And very importantly, a referral to palliative care. And I think this is something that we talk about, but palliative care, a crucial part of the team. It doesn't have to be medical oncology or palliative care. They're combined, they overlap, they manage symptoms. They're a very important part of the team. We depend on them and we work together. So just keep that in mind. Suffering and pain. So just to let you know, pain is a bit like the fatigue. So you have pain, there's a stimulus for experiencing pain, but a whole host of things that go around the actual experience of pain, which can make it worse. So you can have emotional distress. Your previous coping mechanisms for coping with strategies may kick in. Your cultural background may impact on pain, the way your workplace, or if you're the provider in your family, all of these things can add and burden pain. So sometimes the strategy for pain isn't just medication, it's dealing with all these outside issues that are impacting on pain. So that's why the multidisciplinary team, once again, is so crucial. Peripheral neuropathy is the numbness or changing in sensation in your hands and feet, and it can cause numbness, pins and needles, sharp burning pain, and it differs as well. Some chemotherapies cause this, and it can last 4 to 6 months. It's quite common, and for some unfortunate people, it can last a very long time. So we like to get onto it early, and if you experience peripheral neuropathy, you need to let your oncologist know. This is an example of what I said before of the grading scale of peripheral neuropathy, and this is what guides our practice. So it gives us some sort of practice. You don't have to stick to it hard and fast, but for example, if your peripheral neuropathy is disabling, you would stop treatment. You know, if it's only mild, you might just keep going, keep a close eye on it. Prevention, there's not enough evidence. Patients ask me, I had someone recently ask me about ice therapy, cryotherapy, compression and exercise in prevention. There's no evidence to support it. The treatment for peripheral neuropathy, there's dose reduce or stop treatment. There are things that you might come across. Antidepressants such as duloxetine can be used, and it's probably the most evidence behind. And there's not a lot of evidence behind gabapentin, so the anti-seizure medications, but they're quite frequently used for lack of anything else. And there's some therapies that there's no evidence behind. There are some trials that maybe support it, but they're not well-designed trials, or there's not many patients on the trial. So we can't say they work, but they're probably not going to cause you harm. So the guidelines kind of say, if you've run out of all other options and nothing's working and you're suffering, you could have a go at these things. I just thought I'd let you know, I didn't know what scrambler therapy was. This is scrambler therapy. So it's a non-invasive transcutaneous electric stimulation device. I don't know how you do a placebo control with this one, because I don't know, but basically it's about rewiring your nerves. So the pain you get from the nerves, this changes the nerve pathway. They have done placebo controlled studies, but they haven't been, there's some saying it's effective, some saying it's not, so we don't know. Where to from here? So there's plenty of resources, the nurses that surround you, the pharmaceutical companies that provide information packs, there's websites. The only thing I'd say is try to stick on evidence-based websites. Look at the trial information that have been done. There's a website I put on there, Memorial Sloan Kettering. It's a hospital in the US that do basically cancer care, but they've got an About Herbs site. And so if you heard of the latest herb that you think is going to do radical things, put it in and see what the evidence is behind that herb. There's patient guidelines. So like the clinicians have guidelines, there's patient guidelines to all these sites. So ASCO, the American Society of Cancer Oncology, I think, the National Cancer Group, NCCN, both of these groups have guidelines for patients as well. So you can go to those sites and they'll actually they're quite dense guidelines. They're not light reading, but if you want to have a look, You can be referred to specialist teams for specific side effects, such as the menopause clinic at King Edward. Your team and the wider team are always there to help you. And just, I would support you in asking any questions. If you don't get the right question and you're not happy with the advice, or you don't feel you fully understand it, look to another member of your team and go over it again with them. I'm done. Thank you.